A very good morning to everyone and welcome to APICS 2021. We'll be discussing about ARDS today. I'm Dr. Clare Fong from the Department of Respiratory and Critical Care Medicine, National University Hospital, Singapore, and I will be chairing today's session. Today, we are very fortunate to have four renowned speakers, Professor Laurent Brochard from Canada, Prof John Marini from the United States, Prof Carolyn Calfee from the United States, and Dr. Matthew Cove from Singapore to share with us their thoughts on patients with ARDS. Today's symposium will be a sequence of 4 talks, followed by a short Q&A session. The second speaker, Prof John Marini, cannot be with us here today, so for his session, please post your questions in the chat. These will be collated and sent to the speakers, and their replies will be posted on the APICS website. Without further ado, let me introduce our first speaker. Professor Laurent is the Interdepartmental Division Head of Critical Care Medicine in the Faculty of Medicine in the University of Toronto. He is a full Professor of Medicine and holds the Keenan Chair in Critical Care and Acute Respiratory Failure. He is a clinician scientist in the Keenan Research Center for Biomedical Science, Li Ka-shing Knowledge Institute, Department of Critical Care at St. Michael's Hospital in Toronto. He has been the editor-in-chief of the Journal of Intensive Care Medicine from 2001 to 2007 and is currently deputy editor of the American Journal of Respiratory and Critical Care Medicine. He has a strong involvement in research and especially clinical research about mechanical ventilation. He has been at the head of a clinical research network on mechanical ventilation in Europe and leads an international collaborative group on applied respiratory physiology, as well as the Center of Excellence in Mechanical Ventilation in Toronto. The topic of his talk today is physiology-based ARDS settings. Is it feasible? Professor Laurent will be leaving after his talk, so we will have a short 2 to 3 minutes immediately after his talk, should you have any questions for him. I will now hand over the time to Professor Laurent.
Physiology-based measurements to manage mechanical ventilation during ARDS. So my laboratory has been working with a number of companies to get research grants or equipment. And I'm going to discuss a number of relatively new tools which may be used to individualize mechanical ventilation, really based on physiology. So the first one is the driving pressure. And the driving pressure has been really became popular because of this study by Marcelo Amato, which used, I think, a total of 9 randomized controlled trials and their database to look at the best predictors of mortality. So the mechanical parameters which were the most strongly associated with survival, whether it's this tidal volume, whether it's compliance, whether it's PEEP, and one of them was the driving pressure. And I'm going to briefly mention why driving pressure makes a lot of sense. So if you think about compliance of the respiratory system, so compliance is volume divided by pressure. So how much volume you can put in a system for a given pressure. So let's imagine a patient or a normal subject with a compliance of 100 ml per centimeters of water. What does it mean? It means that this is the total compliance. And it's like having in the lung 100 small subunits, each one with a compliance of 1 ml per centimeters of water. If you add together all these small units with this small compliance, the total compliance is the sum of the compliance of each unit. So it will be 100 units with 1 ml per centimeters of water. Now, if this patient got ARDS, and we see on the CT scan that usually like between half and 2/3 of the lung are not aerated on the CT scan. So you have only 30 units left. Well, your compliance will be 30 ml per centimeters of water. So compliance is a direct measurement of the available aerated lung volume. It does not correlate with the severity of the injury. It just correlates with the size of the ventilated lung volume. And this is what was shown by Gattinoni, showing the relationship between compliance and the what they called here the residual inflated lung. So this is the main reason why compliance becomes small and pressure becomes high. So if you think of compliance as being proportional to FRC, let's say the functional residual capacity, and compliance being the volume divided by the elastic pressure, because we remove the resistive pressure, it can be calculated at the bedside as tidal volume divided by the driving pressure, which is plateau minus PEEP. So the driving pressure is the ratio of your volume, the one you set, to your compliance, which is a marker of the available lung volume. So the driving pressure is directly the ratio of how much volume you deliver to how much volume in the lung is available for ventilation. So it makes a lot of sense to see this relationship between the driving pressure and, again, whatever the setting and the severity and the risk of death. So very, very powerful index. And there are multiple examples where you can increase the driving pressure and increase mortality without changing the PEEP, but you can increase the plateau without changing driving pressure and without increasing mortality. And recently, this was shown also to exist in the whole population of mechanically ventilated patients, with an effect over time of keeping high driving pressure. And this is in the database of all mechanical ventilated patients in Toronto. So why would that be important to individualize ventilation? Well, this recent data is again a new kind of reanalysis of database from a randomized trial. And these data ask the questions, do patients benefit from low tidal volume in the same way, whatever their initial compliance or elastance? And the results seem very clearly indicate that the patients who really benefit from lowering tidal volume from, let's say, the classical high to the lower 6 ml per kilogram are really the patients who have high elastance, so meaning low compliance. And for patients with relatively normal elastance, which means normal compliance, well, there does not seem to be a benefit of decreasing tidal volume, where even at very low values of elastance, there may be some worsening. So it may indicate that keeping the low tidal volume at any price with sedation, even paralysis for patients with relatively normal elastance or compliance may not be justified based on this data. The second approach is the knowing how to interpret your pressure and when does your airway pressure becomes different from the alveolar pressure. And this is the case when you have autoPIP, so this is a very classical notion, but this is also the case when you have airway closure, which has been described for many years, but not until recently in ARDS. When you do a pressure volume curve, you slowly inflate the lung and you look at the same time at the increase in volume and the increase in pressure. And this is a small volume. So you see on this part, it's quite a linear increase. But in some patients, which percentage vary across series, but like 30 to 45% of the patients, what you see on the initial part is a very, very steep curve, if you wish. So very little increase in volume for the increase in pressure. For many years, it has been called the lower inflection point, like the beginning of recruitability. We don't think this is exactly the explanation. We think the real explanation is airway closure. What is airway closure? Well, it means this is what happens when you try to empty your lungs, for instance. You always keep some volume in the lung because your airway closed. So this is airway closure happening at the level above FRC for positive pressure. And the demonstration here is that the red curve is the tubing's compliance, the ventilator circuit. So it means in this initial part, nothing is entering in the lung because the airways are closed. And this may be very important to know because the PEEP you set may be set at this level, which we call the airway opening pressure. If you set any PEEP below, you will have a reopening and closing of the airways, which may explain the findings we have at autopsy of multiple small airway injury. And in fact, the simple way to do it is not to do a pressure volume curve, but just a pressure time curve at a very low flow. You see an example of this is classical mechanical ventilation. You decrease the rate, you decrease the insufflation time to have a very low flow. And when you do you look at your pressure curve, you see two slopes. The initial one, which is corresponding to the pressure at which the airways are closed. And you see no change in the esophageal pressure, for instance. And this abrupt change in the slope indicates that you reopen the airway. And in these patients, it's close to 20 centimeters of water. So in these patients, nothing entered into the lung before you reach a pressure of 20, and probably this is where you should set the PEEP. We don't know where it happens. It may vary depending on patients. This is a fascinating study suggesting directly visualizing airway closure in the small airways in an animal model of lung injury by the group of Goran Edenstierna and Sam Bayat. So very nice study. We don't know in humans whether it's always a small airway or the higher airway could also participate. In some series, we found that the incidence was much higher in patients with high BMI. You see body mass index above 40. It's 60% of patients who have significant airway closure. When we say significant, we mean above 5 centimeters of water. And the reason for that, the obese patients, maybe because the intrathoracic pressure is very high. And one way to measure it is to measure the esophageal pressure. So using this patient, in this series, the correlation between BMI and esophageal pressure. And my reading of all the data about esophageal pressure in this patient is that in obese patients, it's extremely useful because it tells you how much pressure is just generated by the chest wall, the load of the chest wall, not the stiffness, just the weight of the chest wall. And it helps you to give the good PEEP just to maintain the end-expiratory transpiratory pressure slightly positive. The next thing which really is important is the recruitability of the lung. And I think we can make big progress at the bedside by individualizing these measurements. You know, the classical technique has been the CT scan, where you compare two CT slices at different pressure, and you calculate how much of the lung is reopened at this pressure. What you would like to do, in fact, is really to come back to the initial pressure and see how much is kept open. So this is very nice to visualize, but this is impossible to do in clinical practice. So what we design is a technique more based on the hysteresis behavior of the lung when you have recruitment, which means that for the same pressure, after recruitment, you have more volume in the system. So we have designed a very simple tool which try to determine how much of the volume will go into the baby lung, how much will go into the recruitable lung, and of course, knowing that the rest of the lung is the non-recruitable lung. So thinking of ARDS as a 3 compartments model. And the technique I'm going to describe very briefly is a very simple test where you drop the PEEP from 15 to 5 in one breath. So the delta pressure is 10 centimeters of water. You measure the exhaled volume during that time, which gives you the volume trapped by PEEP if you want. You subtract the initial tidal volume, and you then measure the compliance at low PEEP. So with that, you can have all the calculations for measuring what we call the recruitment to inflation ratio. I'm going to show you a short video of about 1 minute to show the feasibility of this technique, because this is my point today. So this is a classical control ventilation in volume. We had a small pause so we can measure the plateau pressure. And the first thing we are going to do is to decrease the respiratory rate. So we go from 20 to 8. So to be sure we have no auto PEEP in the system. So relatively long expiration. You see the patient is ventilated with PEEP 15. And the next thing we are going to do is to drop PEEP 15 to PEEP 5 in just one breath. Okay, and then look at the exhaled volume, which is the volume trapped by PEEP. So you see in this case, it becomes more than 800. Then you measure the plateau pressure at low PEEP to give you the compliance of the baby lung. and then you can come back to your initial settings. So that's it. That's a very simple maneuver, which again, just need to be sure the patient is passive, is not breathing spontaneously. And with that, you can measure the compliance of the recruited lung and the compliance of the baby lung. You make the ratio of the two, which we call the recruitment to inflation ratio. And we had already a number of groups in the world which have used this technique, which we validated in the initial paper. And just an example in patients with COVID ARDS, I've shown that previously. You see that there was no difference in the mean recruitment to inflation ratio between COVID and non-COVID ARDS. But more importantly, there were values from very low recruitability to very high recruitability. So a real need for individualizing this titration. The last point I'd like to mention about the physiology-based ARDS setting is when the patient goes to spontaneous breathing. And of course, we do that quite early. So two things. First, you can still measure the driving pressure during spontaneous ventilation. This is an example of a patient under pressure support ventilation. And you see when you do the plateau, you do not always see such a nice plateau because the patient may still be breathing, but very often you have a time for a good plateau, which usually is higher than the airway pressure. The best mode of ventilation to do that is proportional assist ventilation, because during this ventilation, the end of insufflation is exactly the end of patient's inspiration. And this is a nice series of patients who were ventilated for ARDS, switched to PAV, and they were able to monitor their driving pressure. And you see that most of the patients maintain their driving pressure in a safe range, independently of the tidal volume. The authors suggested that this should not be used for compliance below 30 ml per centimeters of water, because the risk of self-inflicted lung injury is too high. But when compliance becomes higher than 30, it's safe to switch to this mode of ventilation. The other index, which is available on any ventilators, is the occlusion pressure, or the PZO1. With Irene Telias, we did a series of studies showing that it's reliable on the ventilators, and it can very well detect when the effort is insufficient, so at risk of disuse atrophy, or when there is a risk of high effort. So two examples here, patient with high P.1, close to 4 or above 4 centimeters of water, and patient very low P.1. So we have ways to monitor the drive and the effort of the patient, which may prevent the worsening we see in many patients at the stage of spontaneous ventilation because they develop self-inflicted lung injury. So in conclusion, this is a great time because we have new tools for having a physiology-based approach for ventilatory settings in ARDS. I mentioned the driving pressure, the airway opening pressure, the esophageal pressure, especially for obese patients, the individual measurement of lung recruitability, and the occlusion pressure plus other indexes to assess the respiratory drive and the amount of effort done by the patients. We have a randomized control trial running actually called Careful Ventilation in ARDS, the Caveat study, which I hope will help to address the clinical relevance and the capacity of these techniques to improve the outcome of patients with ARDS. Thank you very much. I'm happy to answer any questions.
Okay. Thank you, Prof. Laurent, for sharing with us your valuable approaches on how we can better optimize ventilator settings based on physiology. We have some questions from the floor. I think in the initial part of your talk, you mentioned that with patients with high compliance, we may not need to keep tidal volume so low. The question is what is the normal elastance or compliance you were referring to? And do we still stick to actually keeping the plateau pressure to less than 30, or should we just look at the driving pressure in such patients?
Yeah, thank you, Claire. Thank you very much. I think this is a very important question, and we move carefully in that direction, but we have tried to provide evidence that the benefits of the very small tidal volumes, let's say, are really coming from high elastance, patients with high elastance. And the more normal is the elastance, so the higher is the compliance, the less benefit we could see on the looking retrospectively at the database of a randomized control trial, and suggesting that if there is a price to pay, it may not be necessary to go to very small tidal volume, which sometimes, not always, but sometimes mean that you need more sedation for the patient, you may need paralysis. And I think the best approach is not to give a strict threshold. Let's say I gave the limit of 30 ml per centimeters of water, which below which you need always to be careful. But I think this is the benefit of the driving pressure, because if you, for instance, leave the very strict 6 ml per kilogram and you start to go higher, the best way is to look at what's the consequence for driving pressure. And if you're still far below 15 centimeters of water, it's very reasonable to think it's safe. And if it's better tolerated, if it's easier for ventilation, I think it's a good practice. One thing I did not mention in detail is that on some ventilators, you can measure it during pressure support ventilation, and you can have also the same reasoning during pressure support ventilation about patients' effort if it leads to volume which induce high driving pressure. This is a suggestion that maybe the patient needs more sedation, for instance.
Okay, thank you. Our next question is about checking the lower inflection point. There's some question about what mode of ventilation that should be the patient should be on, and what settings should we look at in terms of how low should the flow be.
Yeah, so thank you very much. So first, I indicated the web page called rtmaven.com, because we have different calculators and different videos explaining the techniques. But the simplest is to use volume control ventilation with a low flow and a very low respiratory rate to have a long insufflation. And low flow means lower than 10 liters per minute, because when you do that, you have almost no resistive pressure, so you can assume that the pressure you see is really the elastic pressure. And you don't need to do like the classical pressure volume curve where you try to go very high in terms of volume. You can even use the tidal volume for classical ventilation, because what you are looking for is the first part of the curve. So you could even keep your settings, just decrease the flow, increase insufflation time, and decrease the rate, and just look at the pressure time curve. That will show you whether or not there is an inflection.
Okay, thank you, Professor Laurent. I think that's all the time we have for question and answers for you. Thanks for sharing on these new physiological parameters we can look at instead of strictly just keeping to the low tidal volume, which I think will truly impact patient management more and more in the future. So thank you once again for your time. Very honored to have you with us here today.
Thank you so much. Thank you for the invitation.
Our second speaker is Professor John Marini. He is a member of numerous editorial boards, author and editor of numerous medical textbooks, and a contributor to more than 350 scientific and educational articles. Critical Care Medicine, The Essentials, a text that has been translated into 5 languages, is now in its 5th edition. His investigative work has always concentrated in understanding the cardiopulmonary physiology and management of acute respiratory failure, with an emphasis on patient-ventilator interactions which occur during critical illness. Refining our understanding of ventilator-induced lung injury is a theme he currently pursues at the bench and clinical levels. His talk today addresses if traditional ventilatory strategies should be modified in COVID-19 ARDS. Without further ado, I will hand over the time to him now.
I'm John Marini, and I'm speaking today on should we modify traditional ventilatory strategies for COVID ARDS. I'm speaking to you from the University of Minnesota in Minneapolis in the United States. I have no conflicts of interest relative to this presentation. The first slide I'll show you is this one. Should we change our approach? And this has been an element of controversy. Some say yes and some say no. And it's been a source of heated controversy. And my impression from all my experience and interactions has been definitively we need to not follow all of the guidelines that we normally follow in ARDS. And I'll try to explain to you why I think that's true. Why should we follow the guidelines, or why should we not follow the guidelines? You have to understand that there is some novel characteristics of COVID-19 ARDS, which we'll call CARDS. There are newer concepts in ventilator-induced lung injury which are relevant to CARDS, and we have implications for managing that problem. Probably the most important influence is that the coronavirus not only attacks the alveoli, but affects the vascular side as well, to a much greater extent than we usually see in typical ARDS. That vascular component becomes very important on several counts. It's a nice paper from the New England Journal of Medicine more than a year ago now, indicates that there's a endotheliitis, not just in the lung, but in other organs. But it also causes thrombosis and angiogenesis in COVID-19. And those processes result in some interesting changes. One is that even at the very earliest stage, there is microcystic changes and in the lung, and the lung, even though it has very poor oxygenation, is filled with gas early on. Later, it is not, as I'll show you. The process not only occludes microvessels with clot, but also causes lung fibrosis. And this was recognized at a fairly early point, nearly a year ago, but it's become increasingly impressive to those of us who have taken care of such patients. So the COVID characteristics we need to take account of are these. There's profound hypoxemia and infiltrates, which do qualify as Berlin-defined ARDS, but CARDS is not conventional ARDS. It has early unusual features, radiographically and physiologically. Early on, it's relatively easy to ventilate and oxygenate. The compliance is relatively good. There's an unusually slow resolution of respiratory problems and a progression to consolidation and fibrosis in some patients who do not recover quickly after being under medical care. It generally has high ventilation requirements, but the patient may not have respiratory distress, which you can call dyspnea in the early stage. There's an endothelial, the vascular, which is greater than the epithelial airspace flooding component, at least in the early and middle phases. That leads to hypoxemia due to VQ mismatch, which is much greater than the shunt contribution, and that's quite different than standard ARDS. The clinical characteristics is that there's a tendency for rapid deterioration, and some have attributed this to cytokine storms. That's not consistent. Muscular fatigue, yes, the patient can get tired from breathing in a labored fashion, particularly if the disease is progressive. There's a question about patient self-induced lung injury. Some have contended that it doesn't occur. I happen to believe that it does. Patients can injure themselves by high transpulmonary pressures. And that may lead to a shrinking baby lung and progressive power concentration, as I'll mention as I proceed. There's a high incidence of ischemia and thrombosis and a protracted clinical course. It's actually been called the long hauler syndrome in some instances. Some patients just do not seem to recover their pre-illness status very quickly. This was just early on in the Wall Street Journal in America. I was interviewed for this article. There was a debate that focused on whether established treatment protocols for respiratory distress are helping or harming COVID-19 patients or CARDS patients. And that controversy is resolving, but it's taken a long time for people to recognize the differences. This was the initial stimulus for the heated controversy. It was Dr. Gatnoni's paper with his colleagues saying maybe we're seeing two different kinds of patients. Those that present to the hospital sometimes are severely ill and have very severe ARDS, and others do not. They seem to be quite content with their hypoxemia, even though they feel a little unusual. It's what they had called type L, the light stage of COVID-19 pneumonia. Now here's an example of the L type, the earlier, milder form, and the H type, the later, more severe form. And what you see is that there is a very big difference between certain of these patients who have similar PaO2 to FiO2 ratios that qualify as ARDS. They have infiltrates, but they're quite different. Some have PaO2, FiO2 ratios that are very concerning, but they are gas-filled, the lungs, and others have lungs that are not gas-filled. Now, the pushback has been from a number of people who have looked at epidemiological data of ARDS patients in the pre-COVID era, and they basically have said that, well, if you look at the range of compliances that we see in COVID-19 ARDS, some of them are very high indeed. You're up to 150 milliliters per centimeter of water. That's quite ridiculous, I think, in terms of classification of ARDS that's due to a inflammatory parenchymal process. We think it's, and when I say we, I mean Dr. Gatnoni and I think it is based on timing of observation and maybe the technique of compliance measurement, because many times when compliance is reported, the reporters do not standardize it to a specific PEEP level, but use whatever PEEP level the patient is on. And the higher the PEEP level, especially in patients who have gas-filled lungs, the stiffer it'll appear to be, although it's just simply overinflated. If we look at the compliance range and days from symptom onset, it's been said that some patients have very low compliances and others have very good compliances. And the obstinate critics have said, this is all ARDS and let's use the regular, typical guidelines for ARDS. But we have found in physiological studies that if you standardize compliance for PEEP, the days from symptom onset are definitely related to the compliance that you observe, and it gets worse and worse as time proceeds. There is a light phase to heavy phase or transition over the disease course. This is a typical example of early ground glass infiltrates and crazy paving and gas-filled lungs. It qualifies as Berlin ARDS, but is it really ARDS? As I mentioned before, the amount of gas and the distributions of tissue and gas in ARDS and CARDS are actually quite different. I don't want to go into this in depth because it's perhaps a little too detailed for this presentation, but basically it's not just the amount of gas, but how it's distributed top to bottom from ventral to dorsal. It's more evenly distributed in CARDS. And if you go ahead and match ARDS patients based on venous admixture, for example, you find very different relationships between the non-aerated tissue fraction of CARDS and venous admixture. You notice there's almost no relationship at all here, whereas in typical ARDS, there is a severity to venous admixture relationship, a non-aerated tissue fraction to a venous admixture relationship. This too is different. Given those atypical features, should COVID ventilator management follow the usual guidelines? I like this quote by Bertrand Russell that says, "The whole problem of the world is that fools and fanatics are always so certain of themselves and wiser people so full of doubts." People who have aspired to think that ARDS is a syndrome that can be treated uniformly oppose the idea that we should be changing our rules. A number of articles came out saying such, and I think you can find them easily in the literature, but they're trying to put a square peg into a round hole. It is very different and demands different treatment. PEEP is probably the most important of these features. Our familiar effects of PEEP are to, when it's successful, to recruit lung tissue, reopen vascular bed, better oxygenation, less hypercapnia, stable recruitment. But if it does not open the tissue, it increases the pulmonary vascular resistance. Now, how does that normal response relate to COVID? Well, in early COVID-19, you certainly do get an expansion of the lung. You may have some recruitment. You may have some reopening of vascular bed, better oxygenation, but you also have overdistension, which redirects blood flow, increases dead space, and generally puts the patient at risk for barotrauma, which is more frequent in these diseases and in the COVID disease. Yet, some very smart people have said, respiratory system mechanics of patients with ARDS, with or without COVID-19, are broadly similar, without respecting the time axis we've just been talking about. They say that. And we strongly recommend adherence to evidence-based management, whatever that is that they mean by evidence-based management. If they mean tables, then I think we definitely oppose that. For example, in the ARDSnet, even the lower PEEP, higher FiO2 selection process gives you PEEP values that are really quite dangerous for these people who do not respond well to PEEP, and probably for these people, proning is a better option. Even the most recent up-to-date guidelines, although they're a little bit less aggressive than the ARDSnet table, still suggests that even if you're using 0.7 FiO2, you're in the range of 10 to 14, and they suggest even up to 24 centimeters of water in the patients who are not responding. But they do not take account of the early to late transition. This is what I tried to point out with Phil Dellinger and Daniel Brody, that early on, there's better lung compliance, ineffective recruitment, and all kinds of features that change over time into a very different picture. And if you don't take into account the time factor, you're going to get into trouble. The disagreement is the time factor. Earlier, COVID lungs are relatively compliant, but they oxygenate poorly. There's higher PEEP levels geared to oxygenation, which will overdistend the lungs and appear to give you a low compliance condition. Later, there is often fibrotic contraction, low compliance, impaired mechanics do catch up to impaired oxygenation at that time. There are other controversies. Is PCILI relevant to CARDS? Should we delay intubation? Let me show you a very recently published paper in Chest. I think it's coming out this month. It's already published electronically. 7 patients, among many that we've seen like this, had very low compliance values. These are late-stage severe CARDS. And what did we find? We found that when we pushed on the abdomen, in other words, stiffening the chest wall, we got improved compliance, improved plateau pressures, better compliance, and if we looked at the effect of withdrawing PEEP, even from a low level, we got improved or unchanged conditions. Here's an example. You have constant flow ventilation, you have a plateau pressure, which when you do a belly push, as we call it, drop the plateau pressure quite impressively. Even though it increased the flow resistance, it decreased the plateau pressure and improved the effective compliance, probably because you're reducing the end inspiratory overinflation. Please consult the paper by Kummer, Kummer. I'm one of the authors on that paper, which explains it in more detail. Now, as far as PCILI is concerned, let's consider that the mechanical stimulus for villi is thought to relate to power, the frequency of high stress cycles, the damaging energy per cycle, and the threshold for mechanical injury. That, in combination with the duration of high power exposure, leads to the possibility that you're going to cause ventilator-induced lung injury. Now, if some people would like to just use driving pressure as your a substitute for power, this is an image of a lung in the beginning, the original baby lung. As it gets smaller and smaller with progressive deterioration of COVID, the power that you apply to the airway opening gets concentrated, and the tendency for injury increases. We call this the shrinking baby lung process, which results in a vortex of ventilator-induced lung injury. Unlike pressure itself, which people do not seem to understand must regulate to the size of the shrinking baby lung, power concentrates, and power is instrumental in causing the mechanical stimulus for villi. This happens in part because the microfibrils of the matrix which support the lung progressively deteriorate, load the remaining fibers, and predispose to a progressive damage and a shrinkage of the airspace. There's a progressive strain loading of weak matrix fibrils, putting increasing strain on those that remain. Beside concentrating the power, it increases the stress per fiber. That accelerating failure causes an intolerable fibril strain, progressive stress loading, unit dropout, a ventilation load that's increased on the remaining lung, increase in specific power, that's the power per aerated tissue space, and the process continues. So if that's true, then it's important to intubate at an early time when you're deteriorating. And it's been controversial as to when to intubate COVID-19 pneumonia. Now, clearly, most patients do not need intubation, and it should be avoided if possible, unless there's stability to improvement, in which case you don't intubate. You should try to intervene early. If the patient remains comfortable, stable, and or improving, less is often more. There's no arguments there. But vigorous breathing increases the transpulmonary pressure and violates the objectives of lung protection for reasons we talked about with power, the shrinking baby lung, etc. When the patient also helps to stretch the lung, there is a difficulty, and they tend to stretch the lung more vigorously during vigorous breathing. Sustained high breathing effort and refractory hypoxemia is quite another story. We should not let these people continue to struggle. This will often be a very long haul, as I've mentioned before, and some have even suggested that it would result not only in PCILI and fatigue, but have suggested that an earlier trach for overwhelmed ICUs might be one thing to consider when you have too little facility to facilitate oral intubation and mechanical ventilation. Again, the vascular part of it contributes to the villi vortex, as Luciano and I wrote about in JAMA last year. The reasons not to allow strong spontaneous breathing are that it helps to improve oxygenation, reduces oxygen demand in FiO2, reduces villi risk, avoids ventilator-induced diaphragmatic dysfunction possibly, and avoids fatigue. Over time, the risks of persistent vigorous breathing accentuate, and what we'd like to say is that in the progression from type L to type H, non-invasive support is really appropriate in the early phase, but if patients start to deteriorate, early intubation is the way to go, so that you can take control of the breathing rhythm and intensity. This is all written about more than a year ago now in JAMA, and I refer you to that article because we haven't really changed our viewpoint as time has progressed. Others have, but we have not. Compliance progressively declines. The tendency to retain CO2 initially is very little, and it becomes greater. There's consolidation replacing recruitability, and eventually, over weeks, you get a very difficult situation, such as the one that I described earlier, with fibrotic lungs and very paradoxical responses and overinflation of the remaining few baby lung units at end inflation. So this is the grid we put together relating to time period, and many who oppose what the ideas we're talking about here have suggested that CARDS is the same as ARDS, but have ignored the time period. The takeaway points for ventilating COVID-19 ARDS: prevent vigorous breathing and high transpulmonary pressure, try to reduce ventilatory demands, try to avoid intubation, but intervene early if efforts remain vigorous and the patient is dyspneic. Avoid high PEEP in the early phase and the very late phase where it doesn't work and you have few lung units that you don't want to overextend and may even be hyperinflated, as I showed you in my example with the belly push. Prone positioning is a better option, but it's inconsistently effective. Monitor mechanics and ventilation efficiency, personalized ventilation rather than tables, etc. Prepare for a marathon, not a sprint. Avoid sudden changes and wean carefully. Should we change our approach? I say yes. CARDS is not your standard ARDS, but in another way I say no, because we need to continue to guide decisions by bedside physiology, as good clinicians always have. And I thank you for your attention.
Thank you, Prof Marini, for sharing your knowledge on COVID-19 ARDS and how it behaves differently. Indeed, in the unit that I work in, we do see a spectrum of patients from the L to H phenotype, and we do see that the latter tends towards a prolonged time of the ventilator with difficulty weaning. Moving on to our third speaker, our next speaker is Professor Carolyn Calfee, who hails from the University of California, San Francisco, where she attends in the intensive care units. Her primary academic focus is the pathogenesis and treatment of ARDS. Her current research projects include molecular subphenotypes of ARDS in precision medicine and critical care, the role of environmental exposures, including smoking, air pollution, and novel tobacco products in susceptibility to lung injury, and novel treatments for ARDS. During the COVID-19 pandemic, She has been the UCSF clinical lead and steering committee member for the NIAID-funded immunophenotyping assessment in a COVID-19 cohort study, and she is one of the lead principal investigators for the ISPY COVID clinical trial, a phase 2 adaptive platform clinical trial of novel treatments for COVID-19 associated ARDS. Her talk today is entitled ARDS Subphenotyping. Without further ado, we'll hand over the time to Professor Calfee.
Again, so much for the invitation to the organizers. My name is Carolyn Calfee, and I'm going to talk today about ARDS subphenotypes. These are my disclosures. So I think we all know that heterogeneity is inherent to the current definition of ARDS. This slide shows the current Berlin definition, which of course describes the syndrome of ARDS, not a specific disease. And as a syndrome, it contains a clinically and biologically heterogeneous group of patients. And there are many different ways that we can subtype ARDS. There's no one best or most useful way. Many of those ways are clinically obvious ways, and whether these have been useful or not has been debated since really ARDS was initially defined. I'm thinking of things like ARDS risk factor, trauma, sepsis, etc., direct versus indirect lung injury, severity of ARDS, of course, mild, moderate, or severe, diffuse versus focal radiographic appearance, and most recently, COVID-19 versus typical ARDS. And these phenotypes may have great value in certain settings. However, that's not exactly what I'm going to focus on today. What I'm going to focus on is a different approach to phenotyping that really seeks to tackle the problem of the fact that our clinical trials of pharmacotherapies for ARDS have unfortunately been a litany of failure. This is just a partial list of some of the many drugs which have seemed to cure mouse ARDS and in many cases work in animal models and early phase clinical trials, only to fail, or in the case of corticosteroids, I guess, to be partially successful when it comes to large scale clinical trials. So why might this be? Well, we can think of lots of potential reasons, but one reason might be this clinical and biologic heterogeneity. Now, I introduced this by starting about clinically obvious phenotypes, but I'm actually going to spend most of my talk focused on latent phenotypes, or phenotypes that are not immediately obvious when we look at our patients with ARDS. This figure comes from an article in PLOS One in which you see seashells on the top row that look to all have the same pattern under regular light, but when exposed to ultraviolet light, we can see that there's actually a great variety of different patterns underneath them. And so I'm going to be talking about latent phenotypes of ARDS that are really only apparent when we look at our patients through a different lens. We've used this approach called latent class analysis now and applied it to 5 different ARDS randomized controlled trials. And in all 5 of these trials, we found strong statistical evidence that there are 2 distinct latent phenotypes within the heterogeneous syndrome that we call ARDS. We've used clinical and biomarker data from pre-randomization in these trials, including 35 to 40 variables, about 6 to 8 of which are biomarkers, and I'll show you some of these on the next slide. And in all 5 of these trials, we see that a 2 phenotype model is a significantly better fit for the data than a 1 phenotype model. Consistently, about a third of the patients fall into a category or a phenotype that we call hyperinflammatory for reasons I'll show you on the next slide. And as you can see from the figure on the right, ARDS risk factor differs between these 2 phenotypes, but does not discriminate between the 2 of them. So you can't say, for instance, if a patient has pneumonia, whether they're more or less likely to be in one or the other phenotype. This figure shows the continuous variables that were used to identify the phenotypes on the x-axis, and the standardized variable value, which is a way of descaling the variables on the y-axis. And the variables on the x-axis are sorted from the maximum positive difference between the phenotypes on the left-hand side to the maximum negative difference on the right-hand side. So the variables on the extremes of the figure are the ones that separate the phenotypes. And you can see that this hyperinflammatory phenotype, again, about a third of patients, is characterized by higher levels of plasma inflammatory biomarkers like IL-6, IL-8, TNF receptor 1, and PI1. Whereas it's characterized by lower levels of bicarbonate, so patients are more acidotic, protein C, and systolic blood pressure. Now, we did not use clinical outcomes when we were identifying these phenotypes. We looked only at the baseline variables, so that we then asked, well, how do outcomes differ between these phenotypes? And we see that across these 5 clinical trials, ranging from the mid-1990s to the mid-2010s with sales, we see really profound differences in clinical outcomes, with that hyperinflammatory phenotype having nearly double, in many cases, the mortality of the hypoinflammatory phenotype. And what I'm showing you here is 90-day mortality. Now, of course, this suggests that there's prognostic utility to the phenotypes, but to be frank, that's not especially novel because there are many different ways to prognosticate in our critically ill patients. But I think we've been particularly interested in this work because the response to randomly assigned therapies seems to differ on the basis of phenotype. So if you recall, the alveoli trial compared a high PEEP to a low PEEP strategy in 549 patients. It was a negative trial with no difference in mortality. But what we found here was that when we stratified by phenotypes, we actually found a significant difference in the response to PEEP by phenotype. So if you were in this hyperinflammatory phenotype, patients seemed to benefit from high PEEP. And in contrast, if you were in this hypoinflammatory phenotype, the opposite pattern was observed. We asked a similar question in the FACT trial, which of course compared fluid liberal to fluid conservative therapy and found no mortality difference, though more ventilator-free days in the fluid conservative arm. And what we found here again was that the effect of fluid therapy on death differed by phenotype. So if you were in this hyperinflammatory phenotype, patients seemed to benefit from the fluid liberal strategy, and the opposite pattern was observed in the hypoinflammatory phenotype. And we then asked, well, is this phenotype simply a surrogate for severity of illness? But we did not find any evidence that the effect of PEEP or fluids differed on the basis of APICS score, which is, of course, probably the most commonly used way to adjust for severity of illness in these patients. So it seems to be something more complex than that. We next went on to test whether these phenotypes were apparent and responded differently to simvastatin therapy using data from the HARP-2 trial led by my friend and colleague Danny McCauley in the UK. This was an RCT of simvastatin for ARDS in 540 patients published in the New England Journal. And unfortunately, like most of our clinical trials of pharmacotherapy in ARDS, it was a negative trial with no difference in survival observed between simvastatin and placebo. However, if we stratified by phenotype, what we found was a significant survival benefit in that hyperinflammatory phenotype. So you can see here, if you were in that hypoinflammatory phenotype, there was no effect of simvastatin versus placebo. However, in this hyperinflammatory phenotype, patients treated with simvastatin seemed to benefit compared to those treated with placebo. Now, this is a secondary analysis and certainly needs prospective validation, but it suggests that this latent phenotype may represent a treatment-responsive subgroup. We also tested this question in the SAILS trial, and we found no evidence of benefit from rosuvastatin. I'd be happy to talk about this later in the questions if people are interested. There may be many potential reasons, including a difference in the lipophilicity versus hydrophilicity of rosuvastatin versus simvastatin. But I think it's important to emphasize this did not seem to be an effect across statins. So in summary, we've identified this latent hyperinflammatory phenotype that seems to have consistently worse outcomes and potentially different responses in secondary analyses of RCTs to PEEP, to fluids, and to simvastatin. So might this be a treatment-responsive latent subgroup? It might, but I think before we influence patient care, of course, we have to confirm these findings prospectively. So I'm going to focus the majority and the rest of the talk now on what is needed to move towards prospective testing of these questions in randomized controlled trials. And I'm going to focus on 5 key questions about these phenotypes. First, are these latent phenotypes present in non-randomized controlled populations? Are they generalizable? And I think the answer here is that they do seem to be generalizable. Is it feasible to identify these practically? And we're putting together, I think, emerging evidence that it is, though we still have some obstacles yet to overcome. We'll talk about approach at the end, because I think we've also made some progress there on how clinical trials should incorporate phenotypes. And then I really think we have more questions than answers on specificity, whether these are truly phenotypes of ARDS or of critical illness more broadly, and of mechanism, what the biologic determinants of outcome really are in each of these latent phenotypes. So let's talk about generalizability. Are these latent phenotypes of ARDS present outside randomized controlled trials? Now, the first group to really seek biologic phenotypes in observational cohorts was the MARS consortium led by Lua Boss and Marcus Schultz, in which they applied cluster analysis to a set of about 15 plasma biomarkers and identified 2 groups, which they termed reactive and uninflamed. You can see here that the reactive group, shown on the top on the right, had higher levels of these plasma biomarkers, generally speaking, and had worse clinical outcomes. However, the overlap with the latent phenotypes that I've described to you has yet to be determined. We have been working to identify the latent class-derived phenotypes in observational cohorts using 2 large observational cohorts, one from Vanderbilt University led by Lorraine Ware and one from UCSF. This work was led by Dr. Pratik Sinha, who's a former postdoc in my group. Now, I don't have time to show you all the data on these cohorts today, but I can tell you that they're very different from each other in terms of the demographics, race, ethnicity, severity of illness, and clinical outcomes. Yet, despite that, we found that a 2-class model was the best fit in each cohort, very similar to our prior findings in randomized controlled trials, with similar proportions to our prior randomized controlled trial-based studies. This is just an example of data from the Vanderbilt cohort, the valid cohort, with a similar structure to the figure I showed you previously. And you can see that this hyperinflammatory class is again characterized by high levels of inflammatory plasma biomarkers, low levels of platelets, protein C, and bicarbonate and systolic blood pressure. When we looked at clinical outcomes, we see that once again, this hyperinflammatory group in both cohorts has dramatically worse in hospital mortality as well as ventilator-free days. So the take-home point of these slides that I've shown you is really that ARDS phenotypes are not confined to randomized controlled trials. Now let's talk about feasibility. How could we practically identify these latent phenotypes? Of course, you can't go to the bedside and do a latent class analysis on a single patient, nor can you really use 35 variables, practically speaking. So we've been working to try to use a smaller set of variables to identify these latent phenotypes. And what Dr. Sinha, pictured here, did was to derive these models in ARMA, alveoli, and FACT as a combined cohort of over 2,000 patients, and then validate the models in 3 independent ARDS cohorts. And this work was published last year in Lancet Respiratory. In the interest of time, I'm just showing you the performance of the parsimonious biomarker model in the largest validation cohort, which was the SAILS cohort of almost 750 patients. And you can see that both a 3-variable or a 4-variable model compared to phenotype by latent class analysis as the gold standard really performed pretty accurately for identifying these phenotypes with an area under the curve of 0.94 to 0.95. It turns out that multiple different models performed quite well when we examined the top 6 variables that were consistently the most useful for classifying the phenotypes in the derivation cohort. You can see that various different combinations of 3 or 4 of these variables all performed really quite well in the validation cohort with areas under the curve of 0.9 to 0.96. We've gone on to start testing this work prospectively. So in work, again, led by Dr. Sinha in terms of the analysis, and with patient enrollment and recruitment led by Drs. Macaulay and Sukhmani from the UK, we applied this scheme prospectively to 39 patients with COVID-related ARDS using a novel point-of-care assay that measures IL-6 and TNFR1 in real time. So we were able to measure these biomarkers in real time, combine them with the clinically measured bicarbonate level, and then assign the patients in real time to a phenotype. Now, the sites were kept blinded to this assignment in order not to influence their patient care. And what we found was that using that model that Dr. Sinha had developed and a cut point from the prior studies, about 1 out of 5 of the patients were hyperinflammatory, which is interesting because that's a lower prevalence than we had found in typical ARDS. Yet that hyperinflammatory group did have a dramatically higher mortality, 63% versus 39% in the hypoinflammatory group. Now, I think we have to take this data with a big grain of salt because, number one, it's a small data set. Number two, this was the first surge in the UK back in spring 2020 when we know that mortality was quite high. But we think it's exciting because it demonstrates the feasibility of real-time phenotype classification. Yet we still need widespread availability of point-of-care assays in order to make this work. And the ongoing FIND study that's being led by Danny Macaulay in the UK is going to test this feasibility in a larger scale study. I just want to mention this very briefly. We recognize that the availability of point-of-care biomarker testing has really been a big barrier for us in terms of trying to move this work forward towards testing in prospective studies. So we have been working to try to develop a clinically useful model that uses only clinical variables. And this is work led by Dr. Sinha and Dr. Cherpek from University of Wisconsin that uses a machine learning model called XGBoost to classify the patients using only readily available clinical data. This figure shows the top 10 variables that were most useful in that. And using this machine learning approach, we can achieve an AUC of 0.95 in a validation cohort, again, the sales cohort. But I think we have to, take this one step at a time. It's a big step to go from using these models in randomized controlled trials to applying them prospectively. And so that's what we're working on now. All right, let's talk about specificity. Are these really phenotypes of ARDS, or are they actually phenotypes of critical illness? And I'll give a punchline away, which is that it's looking like it might be more of the latter. Now, the first important paper on this work was published by the Pittsburgh group led by Georgios Kitsios, in which they applied both latent class analysis and an earlier version of that parsimonious model that I showed you a moment ago to a group of patients with ARDS, as well as a group of patients with acute respiratory failure who were at risk for ARDS but did not meet criteria. And what they found was that using both latent class analysis and this parsimonious classifier model, that they were able to identify distinct phenotypes, even within this at-risk group, suggesting that the phenotypes may not be, in fact, specific for ARDS. Subsequent work that's in press for the Blue Journal out of Lou Abbas's group has applied both the Mars group's reactive versus uninflamed clustering approach, as well as the parsimonious model phenotyping approach derived from latent class analysis to mechanically ventilate patients without ARDS, all right? So patients that are just mechanically ventilated but don't actually qualify for ARDS. And what they found is that both of these phenotyping approaches are associated with higher mortality in this group, even after adjusting for age, gender, and Apache score. Now, this suggests that these phenotypes have prognostic value. That doesn't necessarily imply that they will confer differential response to treatment or identify differential response to treatment, but it's certainly the first step in that direction. So these latent phenotypes may in fact not be unique to ARDS. However, I think it's really an open question as to the extent to which they're present in other critical illness syndromes like sepsis and acute lung injury. Similarly, the overlap with the transcriptomic phenotypes of sepsis that have been described by many different groups is unknown. But it certainly raises the idea that these might represent a treatable trait that spans across syndromes, meaning that there are distinct patients within groups of patients categorized by syndromes like respiratory failure, ARDS, or sepsis that may, in fact, share similar clinical and biological features and might respond similarly to treatment, though that hypothesis remains to be tested. And this is a figure developed by Kiran Reddy, an excellent postdoctoral fellow in Dublin, for an editorial in the Blue Journal on the paper I just showed you. All right, so now let's talk about mechanism. Is inflammation really the driving difference? And I kind of regret applying the moniker of hyperinflammatory and hypoinflammatory to these phenotypes because we don't actually know that that is the driving difference. It's certainly not as simple as inflamed versus less inflamed. And I just want to show you some data that's work in progress from our group related to COVID-19 ARDS that I think just points to the complexity of the problem that we're dealing with biologically. So I think we've all seen the data now that suggests that plasma inflammatory biomarkers are similar to, in fact, lower in COVID-19 as compared to non-COVID-19 ARDS. The figures from the top are from Peter Picker's paper in JAMA showing levels of TNF, IL-6, and IL-8 in COVID-19 ARDS being lower than in typical ARDS. And those from the bottom are from colleagues at Stanford, published in JCI Insight with a slightly different set of biomarkers, but sending a similar message that at least circulating inflammatory markers seem to be lower in COVID-19. Yet we have this very striking benefit of steroids in contrast to typical ARDS. The figure on the top is from the recovery trial where we see that mechanically ventilated patients with COVID-19 had a major mortality benefit when treated with dexamethasone. And in contrast, the line at the bottom is from a Cochrane review of steroid therapy in ARDS from 2019, summarizing decades of trials and still insufficient evidence to conclude with certainty whether corticosteroids are effective. So what is responsible for this difference? Well, we wondered if some of these differences might be driven by the immune response in the lung. And so I'm just going to show you one slide of data, but I think it's really interesting data. And this work has been led by Artik Sarma, who's a clinical instructor working in my group at UCSF, as well as by two outstanding junior faculty members, Chaz Langelier and Steph Christensen, also at UCSF. And what we did was to apply tracheal aspirate metagenomic sequencing to patients with COVID ARDS versus typical ARDS as compared to mechanically ventilated controls. And when we did that, we identified 696 differentially expressed genes between COVID ARDS and typical ARDS, and you can see the heat map of these here on the right-hand side of the figure. And you can see that it's actually considerably more complex than just inflamed versus not inflamed. The figure on the right-hand side shows what's called a pathway analysis. And just to orient you to how this figure works, you can see that COVID ARDS is the reference group here in red. Typical ARDS is shown in purple, and mechanically ventilated controls are shown in gray. So for instance, for the top line here, HIF1 alpha signaling, there's greatly increased signaling of that pathway in typical ARDS versus COVID ARDS, and P10 signaling at the bottom, there's decreased signaling for that pathway in COVID ARDS, or in typical ARDS versus COVID. And I just want to point out some of these canonical biomarkers here, canonical biomarkers of innate inflammatory response like IL-6, IL-8, and IL-1, where you can see that in fact COVID ARDS is relatively underexpresses those pathways compared to typical ARDS. And in contrast, you see here both PPAR and P10 signaling, where COVID ARDS has relatively higher levels of expression of those pathways compared to typical ARDS. So this is just to say that the complexity of these pathways in our patients is incredibly intense, and we have to really take a humble and curious approach to understanding this biologic complexity. It's certainly not as simple as hyperinflammatory versus hypoinflammatory. All right, well, with all of that confusion and sort of uncertainty, how could we possibly move forward towards incorporating phenotypes into trials? Now, this could be its own separate talk, so I want to acknowledge that what I'm going to tell you is very sort of focused, but I think the most important thing is to think about ahead of time the fact that we know there's clinical and biologic heterogeneity within ARDS, and we should approach that thoughtfully when designing trials. Now, the least effort and the least efficient approach is to, of course, do a pre-specified subgroup analysis, right? Where you complete the trial and you say, okay, well, when I get to the end of the trial, I'm going to look back at these specific subgroups. But of course, that requires you to complete the whole trial and to really enroll enough patients in each subgroup that you have the power to analyze them separately. I think we have to be extremely careful about trials that focus on only one phenotype, because our hypotheses about what might work in each phenotype might be quite wrong. And I'd point you to Nuala Meyer's terrific paper in Critical Care Medicine in 2018 that showed that in fact, when she analyzed the anakinra trial on the basis of IL-1RA levels at baseline, the differential response was in fact exactly the opposite of at least what I might have predicted. So I think we have to be really cautious about that, because we might end up actually causing harm to our patients. So how could we acknowledge this uncertainty and yet move forward? Well, I think adaptive trials with phenotype-based stratification really represent an exciting possibility for how to do this. These type of trials are being done in breast cancer, asthma, and other fields, and it allows you to learn as you go and enable unexpected discoveries. I'm just going to show one slide that sort of describes a very simple adaptive trial and sort of plant this as food for thought as to how we could move forward in this field. So let's say you have a group of patients that are stratified into two subgroups. We could call them hyperinflammatory and hypoinflammatory. Now, both patients start off the trial being randomized 50-50 to treatment or control. And then at an interim analysis, you can decide to stop and for futility in both groups. You could continue for both groups if there appears to be effect in both groups, or if there's response only in subgroup S, the smaller subgroup, you could continue with that group and drop the other group. All right, so that's a very simple adaptive trial. Now, of course, we can get more complex with response adaptive randomization, with incorporating these designs into platform trials. But this trial design can allow us to acknowledge our uncertainty, get our interest in identifying treatment response subgroups, and respond during the context of the trial in order to make it more efficient. All right, so in my last minute or so here, I just want to end with the concept that we have to approach this with a humble and flexible attitude. And I really like to remind us all of this quote from the famous British statistician George Box that says, "All models are wrong, but some are useful." Now, if I've shown you that we can take a group of ARDS patients and we can stratify them on the basis of a 3 biomarker model into 2 groups, and these 2 groups may respond differently to therapies. Now, that is, I think, what we've shown so far. But what happens when we add additional layers of complexity? What happens when we add genomics? What happens when we add metabolomics, proteomics, or measures of the microbiome? Well, I think as that example from the tracheal aspirate metagenomics shows you, we are going to identify much more complexity, right? It is not as simple as these are the only 2 groups of ARDS patients, and this is the only way to phenotype them. Every patient at some level is their own phenotype, and the best way to group patients may very well depend on the treatment under study. It's possible that we might at some point end up redefining critical illness, at least for the purpose of clinical trials, away from syndromes and towards biological phenotypes or treatable traits. But whether that approach is actually going to be useful or not is a hypothesis that needs to be tested prospectively. So in conclusion, we've identified these 2 latent phenotypes within ARDS in 5 randomized control trials with differential responses to mechanical ventilation, fluids, and pharmacotherapy. We see these phenotypes in observational ARDS cohorts as well, and likely in patients at risk for ARDS. And bedside identification is not quite here yet, but may be feasible soon. At the same time, the driving mechanistic differences between these phenotypes are not clear, so we really have to remain humble about the biologic complexity we're facing. Adaptive trials may allow us to learn as we go which treatments work best for which phenotype, and of course, prospective confirmation is going to be needed before patient care should be affected. Thanks very much, and I look forward to answering your questions.
Thank you, Professor Calfee, for sharing your insights on the subphenotyping of ARDS and how this might have a further impact on our management strategies in the future. Our last speaker for this symposium is Dr. Matthew Cove. Dr. Cove completed an internal medicine residency in Portland, Oregon, and a critical care fellowship in Pittsburgh. He moved to Singapore in 2012, where he works as a critical care consultant and holds a joint position at the Yong Loo Lin School of Medicine, National University, Singapore. His clinical appointment includes providing consultant cover in the medical intensive care unit, and his interests include development of novel extracorporeal ventilation support devices, ventilation, and sepsis. Since arriving in Singapore, Dr. Cove has received continuous funding to develop a research lab focused on extracorporeal respiratory support research, and he holds a large collaborative grant with colleagues at institutions in both Singapore and Munich to develop novel infection detection markers. His talk today will be on extracorporeal carbon dioxide removal, and without further ado, let us begin.
Committee for inviting me to talk during this session on extracorporeal carbon dioxide removal. And before I go into my talk, I think I just want to ask you all a question. Now, this is an ARDS session, and I want to ask you to think about, when was the last time you managed an ARDS patient and found yourself at the bedside thinking, what this patient really needs is some carbon dioxide removal? Now, the reason I ask that question is because I'm willing to bet that it probably doesn't happen very often. In fact, it may have never happened to you. And I'm willing to bet also that you probably more likely stood at the side of the bed with an ARDS patient and thought to yourself, I need ECMO to help this patient, or asked yourself, would ECMO help this patient? So with that in mind, I think I would choose to retitle this talk as Extracorporeal Carbon Dioxide Removal, What's the Point? And what I want to talk about really is how maybe ECCOR can help our ARDS patients. Now, of course, the application of ECCOR is not restricted to ARDS, but I think for the purposes of this session and the fact that we only have 20 minutes to talk, we'll focus on ARDS. Now, for the uninitiated, what is ECCOR? Now, if you've never used ECCOR before, never come across ECCOR before, it's probably simplest to think of it in terms of a dialysis circuit. And you can see from the diagram here, this looks very much like a dialysis circuit, right? We take blood out of a vein, We pump it through a device where exchange occurs. In this case, it's gas exchange instead of solute exchange in dialysis. And then we return the blood to the patient through either the same vein or a different vein. Now, the difference between ECCOR and dialysis, of course, is what happens in the exchange device. Here, we're exchanging gases. And why is that happening? Well, it's because instead of having liquid permeable fibers, in a gas exchanger, we have hollow fibers that are impermeable to liquid, but permeable to gas. What does this mean? Well, this means that if your sweet gas flowing through your hollow fibers contains very little carbon dioxide, then carbon dioxide is going to diffuse out of the blood, down its concentration gradient, into the sweet gas, and be exhausted out of the device. So you're removing carbon dioxide. This diagram here just shows how the fibers are orientated. It's a little bit different to dialysis. They're kind of in a network mesh, and this just improves gas diffusion. Same concept is used in ECMO. And since I bring up ECMO, then of course, anybody who's looked at an ECMO paper will realize, look, this ECCOR circuit, it doesn't look very different to a VV ECMO circuit. So what is the difference? Obviously, there's some color differences on this diagram, but the main difference is something I can't show in a diagram, because the main difference, and you'll probably already guessed this, is the flow rate. And the only clue to the different flow rate in ECMO is the fact that ECMO generally has a heat exchanger. And this is because the flow rate is so much higher with ECMO. Now, why do we have these different flow rates? And again, I risk insulting you as an audience, because what I'm now talking about is really high school physiology, the difference between the way oxygen is transported and the way carbon dioxide is transported. We'll all remember from our high school biology lessons, right, that oxygen is transported bound to hemoglobin. It's no great mystery there. But sometimes maybe we forget that hemoglobin displays saturation kinetics. And what does that mean? That means that when the hemoglobin has bound or is 100% saturated, i.e. it's bound as much oxygen as it cannot bind any more oxygen. So there's a limitation to how much oxygen a liter of blood can carry. The same is not true for carbon dioxide, because carbon dioxide is not transported bound to a protein, it's transported in the form of bicarbonate. So carbon dioxide produced as a result of cellular respiration is converted to bicarbonate and dissolves into the plasma. Now, when we start talking about what this means in terms of numbers, we can very quickly understand why ECCOR is so different to ECMO. Now, a liter of blood with a normal hemoglobin concentration, because of saturation kinetics, is only able to carry around 50 to 60 mils of oxygen. Now, a normal person under normal respiration circumstances will probably be consuming somewhere around 250 mils of oxygen a minute. So that means if you're trying to do ECMO where you're delivering oxygen as well as removing carbon dioxide, you're going to need a blood flow in the range of 5 liters per minute to deliver this 250 mils of oxygen, since each liter can only carry 50 to 60 mils of oxygen. The same is not true for carbon dioxide removal, because you know from the last blood gas you looked at, each liter of blood contains around 25 millimoles of bicarbonate. Now, if we're consuming 250 mils of oxygen per minute, that means we're also producing 250 mils of carbon dioxide, right? So 250 mils of carbon dioxide, when it's converted into bicarbonate, works out to be around 10 milliequivalents, right? 10 to 11 millimoles of bicarbonate. So that means every liter of blood contains more, or about twice the amount of the metabolically produced CO2. So if your goal is simply to remove CO2, you can do it with a much lower blood flow, 1 liter per minute or less, depending on how efficient your device is, compared to oxygenation, which we try to do with ECMO, which requires a much higher blood flow rate. Now, what does that mean? That means with the lower blood flow, we can get away with smaller cannulas. The lower blood flows require less complex pumps. Less complex pumps and smaller cannulas translate to better safety, much easier to use. And in fact, because the blood flow rates can be down to 400, 500 mils a minute, you can even have pumpless devices. So these are devices that don't even have a pump. They rely on the patient's heart to pump the blood through the ECCOR circuit, essentially using the AV gradient to pump blood through. So what do these devices look like? Well, first of all, I want you to think about the difference this means in terms of ECMO versus ECCOR. Now, I've chosen a McLaren sports car here to represent ECMO. It can do a lot of fancy things, you know, not just carbon dioxide removal, but oxygenation. And not only that, with the higher flow rates, it can provide cardiac support as well as respiratory support. Now, anybody who works in Singapore will recognize the reason I chose a McLaren to represent ECMO is, of course, because Graham McLaren runs the ECMO program at my hospital, NUH. Now, in comparison then, ECCOR seems not as impressive, right? Doesn't do as much. It might be like a bicycle compared to a sports car. But there is a key difference, because if you think about a street like this, you can access a street like this with a bicycle, but you might not be able to access a street like this with your fancy McLaren P1 or whatever this is. So ECCOR, in comparison to ECMO, can go to places, because it's safer and has lower flows, it can go to ICUs that don't normally do ECMO. And in fact, when you get down to the blood flow rates of 500 mils a minute, you're in blood flow rates that are comparable to dialysis. So people who are doing dialysis in their ICUs might be comfortable doing ECCOR, whereas they won't be comfortable with the 5 liters a minute of ECMO. So what devices do we have available to us for ECCOR? Well, based on this nomenclature paper back in 2018, we can think of ECCOR as 2 branches. One is AVCOR. These are the pumpless devices that we rely on the arteriovenous gradient. And then the VV ECCOR devices, things like the Novolung ILA Active. Now, these have the capability of going right up to ECMO flow rates, or more concentrated low flow devices like the Hemolung. Sorry, this is an old slide of a Hemolung. They've updated the device since this. Now, when we're talking about low flow, we're really talking about flows of less than a liter per minute. When it comes to low flow devices, there are probably 3 that are available. The ambular cap by Belco, which has now been taken over by Medtronic. I've not actually seen that used outside Europe. We have the Hemolung. This is the newer version of the Hemolung. This has been used in Europe and the US. And then the Prismalung Plus is replacing Baxter's Prismalung. I think that's been used in centers in Europe already. It's not available certainly in Southeast Asia yet. But the question is, if we're going to use ECCOR, low flow is probably safer than the full flow. And we're going to be more comfortable with it because, as you can see from these diagrams, these devices, they look like conventional dialysis devices. And in fact, the Prismalung Plus is just tagged on to the Prismax dialysis machine. But if we're going to introduce low flow ECCOR, we have to understand its limitations, because first of all, it's not ECMO, it's a no-brainer. It's not full ECCOR, so it's not going to remove all the metabolically produced CO2 or even have that capability. And perhaps most importantly, if you've got an ARDS patient and you simply put them on low flow ECCOR and don't do anything else, it's not even going to help your patient. So you have to think differently. You have to think, how is this ECCOR going to help me manage my ARDS patient? And this is where it gets interesting. So what can ECCOR do, and what can low flow ECCOR do? Now, this is one of the first ECCOR studies. You can see it's published a long time ago now, 1977. This was done in sheep. And what they did was they put sheep on ECCOR and they cranked up the CO2 removal. So along this bottom baseline, this is the percentage of metabolically produced CO2 that is removed by the ECCOR circuit. You can see that when you approach removal of 100% of the metabolically produced carbon dioxide here, what happens is ventilation by the sheep decreases by close to 100%. They almost stop breathing. Now we know from our physiology days, this is a no-brainer, right? CO2, and rather pH as a result of CO2, is one of the primary determinants of respiratory drive. But look at what happens if you have, say, low flow ECCOR that removes maybe around 50–60% of the CO2. You still get a substantial decrease in ventilation. So what does this mean for our patients? It means for a patient on the ventilator, if we put them on some form of ECCOR, even low flow ECCOR, it gives us the opportunity to uncouple the ventilation and oxygenation functions that we do with the ventilator, because we can do some of this ventilation now with our ECCOR circuit. And why is that important? Well, I'm sure in this session already someone has been talking to you about lung protective ventilation and the use of lower tidal volume ventilation. You're all familiar with this study, right? This is the 2000 ARDSNet study. Ever since 2000, really no one has questioned the importance of lower tidal volumes in ARDS. And what they showed in this study, as you all know, is that if you start with a lower tidal volume, start at somewhere around 6 mils per kg ideal body weight, and you titrate that volume between 4 and 8 mils per kg to target a plateau pressure of less than 30, then your patients do better than if they're on a higher tidal volume targeting a higher plateau pressure. But the interesting thing is that study compared a plateau pressure of less than 30 versus a plateau pressure of less than 45. But the reality is we don't know what the safest plateau pressure is. And in the next few slides, I'll even raise the question, do we even know what the best target is? Is it plateau pressure, tidal volume, or even driving pressure? Why do I raise this question? Well, this is another old study now. This was from Dave Hager. Look at what he showed. He took the ARDS data and he said, well, look, is there a plateau pressure at which mortality seems to level off? I.e., is this the ultimate target plateau pressure? And you can see just from this slide of the study, whether patients were on the lower tidal volume or the higher tidal volume, if you categorize the patients in terms of quintiles based on the plateau pressure, you can see in this slide, look, no matter how low the plateau pressure was, mortality never seemed to level off. It starts to raise the question, well, should the target be as low a plateau pressure as possible? Now, this is an interesting study. This is starting to get old now. This is almost 12 years ago. What they did in this study was they took patients with severe ARDS. It was around 30 patients. And in the patients whose plateau pressure was greater than 28, what they did, and that's this column here, they dialed down their tidal volume until their plateau pressure came down below 25. What they found in those patients was the markers of pulmonary inflammation dropped when they turned down the tidal volume. Now, this group of patients here, these are patients that had severe ARDS, but their plateau pressure was already below 28, so they didn't adjust the tidal volume. but essentially most of these patients had their tidal volume dialed down from 6 mils per kg ideal body weight to 4 mils per kg. What did that mean? Well, they got improvement in pulmonary inflammation, but you can see what happened when they went to these lower tidal volumes. All the patients experienced a jump in their CO2 level, some as high as 80 plus. Right, now you can see their CO2 level was quickly controlled, and they did this using a low flow ECCOR device. You can see the reciprocal changes with pH. So this raises the question, okay, if we want to dial down our plateau pressures, we've got to deal with the CO2. And the way to deal with the CO2 is an ECCOR device. Now, what does this mean for our patients' mortality? Well, it's not really been studied in many randomized controlled trials. But one important thing, and this was a sort of meta-analysis pulling a series of studies together, they looked at how PCO2 levels at 48 hours affected ARDS mortality. You can see it's sort of a U shape, right? But the key thing I want to highlight is, look, in patients at 40 whose CO2 is greater than 50 at 48 hours, their mortality is higher than patients that have a more normal CO2. And patients with a lower CO2 also seem to have a higher mortality. Now, if we use this device in a randomized controlled trial, this is one that was published now, 8 years ago. What they did here was they targeted tidal volume. So randomized patients to 3 mils per kg supported by AVCOR versus 6 mils per kg. Look at what happened. They were able to get their ventilator patients, they were able to get their AVCOR patients off the ventilator faster. It became significant in patients that had the more severe ARDS. The PF ratio was less than 150. Look, they got off the ventilator much, much faster, i.e. they had more, significantly more ventilator-free days. But before we get too excited about that, I want to draw your attention to mortality in this. They were unable to show a significant mortality difference. But also I wonder about this because, look, their mortality in their control group, these are ARDS patients with a PF ratio of less than 150. Their mortality is 10% in the control arm. My patients with ARDS, this is moderate to severe ARDS, their mortality is not as low as 10%. So in many ways, this study was just not powered enough to detect a mortality difference. The other important thing is they used AVCOR. And of course, AVCOR, if you're cannulating the femoral veins and you're relying on the patient's AV gradient, this is going to give you trouble because you can't prone your patient. And I think most of us in the modern era would prone our patients, certainly after actually it was around 2013 that we saw the proning study published, the Proceva study. So I'm not sure what this study means for current ECCOR technology in ARDS. But we also have to ask the question, is it more than just tidal volume and plateau pressure? Well, you'll have seen these slides in other studies, so I'm going to go through them very quickly. But essentially, what Marcelo Amato showed in 2015 was, look, maybe it's not just tidal volume or plateau pressure, maybe it's driving pressure. And in this study, it quite clearly showed, look, if you fix the driving pressure, regardless of what your plateau pressure is, mortality is unchanged. Whereas if your plateau pressure is flat, but your PEEP comes up, i.e. your driving pressure is high here, low here, look at what happens to mortality. What he was able to show was, look, driving pressure predicts mortality probably better than tidal volume and plateau pressure. This was a meta-analysis Unlike the Amato paper, they looked at some studies published after 2015. Again, they showed the same thing. Like, driving pressure seems to predict mortality. Now, this becomes important when we consider the more recent supernova study. Now, what they did was they used ECCOR to try and drive down the plateau pressure by driving down the tidal volume, but in doing so, they also changed the driving pressure. They took about 95 patients. They, when they were on 6 mils per kg, they dialed up their peak till their plateau pressure was around 28 to 30. They then dialed down their tidal volume to get their plateau pressure below 25. And then, because CO2 rose, they put them on ECCOR to control their CO2. So they were able to control CO2. But look, driving pressure dropped down from sort of 13, 15 range down to around 10. Now, this is important when we consider Marcelo Amato's study, because look, driving pressure of around 10 is associated with a lower mortality compared to 15 or higher. So ECCOR helps us get our driving pressure down, our tidal volume down, while still controlling CO2. Now we have to wait for the REST study to be published. This should be published hopefully within the next year or so. I know they've completed recruitment. They recruited around 1,000 patients and randomized them to low tidal volume supported by ECCOR versus conventional low tidal volume ventilation. We'll be excited to see the results of that. But just finally, think about what's coming in the future. This is a study we published ourselves about a year ago. We asked the question, well, how can we make low flow ECCOR even safer? Well, we can make it safer by removing the membrane lung completely and just using a conventional dialysis circuit. And this is what we did here. We modified our dialysate to remove bicarbonate. And we were able to show that with conventional dialysis, with bicarbonate removed from the dialysis solution, we were able to lower plasma arterial carbon dioxide. We need to modify this, but moving forwards, and there are some other groups working on similar products, I think in the next 5 years or so, we could see ECCOR devices that are certainly no more complex than a conventional dialysis device coming into our ICU. So in conclusion, let's remember ECCOR is not ECMO. It's not going to do as much, but it offers some versatility. It allows us to bring extracorporeal dialysis support into ICUs that wouldn't ordinarily offer ECMO. And I think in the very near future, it's going to become technology that's no more complex than providing the dialysis we already do in our ICU. I apologize, I may have run slightly over time. Thank you.
Okay. Thank you, for, Dr. Cove, for sharing with us on ECCOR, which many of us are not as familiar with. We will now have a few minutes for question and answers. Two of our speakers, Professor Calfee and Dr. Matthew Cove, will be here to answer some of the questions live. So I think one of the questions that was posted in the chat is directed to Professor Calfee. In terms of the different subphenotypes of ARDS, do they remain stable over the course of the disease, or would they change over the course as ARDS progresses? Thank you.
Yeah, thank you for asking that. That's a really interesting, great question. So we have reported that the phenotypes appear to be stable over the first 3 days of enrollment in randomized control trials. We tested this in the ARMA trial, which is the low tidal volume trial that, of course, that Dr. Cove was just referring to, as well as the alveoli trial of low versus AC. And in both of those studies, we saw the phenotype assessment remain stable in about 95% of patients over that time period. Now, a couple of important caveats. Those studies were completed now about 20 plus years ago. So how relevant that is to our current patients remains unknown. We also don't know what happens before that, what happens after that time period, but at least for that 3-day time period, phenotype assignment seems to be relatively stable.
Okay, thank you. And I think you did mention that the different subphenotypes do have different an impact on management strategies in terms of different PEEP, as well as whether fluid liberal or fluid conservative strategy. In your clinical practice, do you find that identifying these different subphenotypes really do change your management of the patient, and would the cost of sending for these additional tests in the future justify the outcomes?
Yeah, those are great questions. So I want to be really clear that I have not changed my clinical practice at all on the results of, on the basis of these analyses. These are all secondary analyses, retrospective analyses. We could be more pejorative and call them subgroup analyses. But really, we have not proven that treatment should be changed on the basis of these phenotypes. We need to develop the methods to test and identify them prospectively, which is what we're working on. And then once we have done that, then I think we'll be able to really test this question prospectively. Does using this type of strategy actually improve outcomes? Does it allow us to detect really a treatment responsive subset in a way that should alter our management?
Thank you very much. The next question is directed to Dr. Cove. Do you see a feasible role for ECCOR in patients who are spontaneously breathing or ventilated, patients with spontaneous efforts to reduce patient self-inflicted lung injury?
Yeah, actually, it has been used as an alternative to intubation in some patients, predominantly in asthma and COPD exacerbations, where the CO2 retention is somewhat driving the patient's respiratory distress. And in those circumstances, ECCOR has been successfully used as an alternative to intubation. And then, of course, you're taking away the negative effects of the positive pressure ventilation, which is really what we've just been talking about for the last hour or so. So I think it has real potential in those patients. Now, the caveat is when people have looked at the use of ECCOR in COPD patients, there was a nice randomized controlled trial not too long ago. It didn't show the mortality benefit we expected to see, but some of that is probably related to the fact that higher flow ECCOR was used. And of course, with the higher flows come side effects, and of course, you're having to anticoagulate these patients, which introduces additional potential for complications.
Okay. The next question to Dr. Cove would be, would it be possible to actually run dialysis and ECCOR at the same time?
Yes, absolutely. Some devices are actually available to do that. Braun, Fresenius, and Baxter all have devices that can provide both low flow ECCOR and dialysis within the same circuit. There are some things to consider in terms of the efficiency of ECCOR. So, for example, if you've got a dialysis circuit and you're providing solute exchange before the blood enters the gas exchange device, if you've corrected the pH somewhat and then you're trying to remove CO2, your CO2 removal becomes less efficient because at slightly more normalized pHs, less of your CO2 is sitting as CO2 than as bicarb. So most efficient devices have the gas exchange device in front of the dialysis filter. So it goes through the gas exchange device before the dialysis filter. But not all circuit orientations are like that. So paying attention to circuit orientation has a big effect on the efficiency of carbon dioxide removal.
Thank you. The next question is to Professor Calfee. In your studies, did you use cutoff values for the variables in identifying phenotypes, such as the IL-6, protein C, as well as bicarb? Were there specific values that were used?
Yeah, that's a great question. So we did not use cutoffs. What we did is we developed a basically regression model that takes the values of those biomarkers, the IL-6, protein C, bicarbonate, et cetera, and puts them into a mathematical equation that generates then a probability. And that's a probability of belonging to the hyperinflammatory phenotype. That probability can range from 0 to 1, and you can pick a cut point for that probability at various levels, depending on whether you want to maximize sensitivity or specificity. But it really takes into combination. It's a way of combining information from all of the biomarkers rather than picking specific cut points for each biomarker, if that makes sense.
Yeah. I guess further trials will be needed to actually identify the particular cutoff values if we were to actually employ some of these variables in bedside identification of patients with subphenotyping of ARDS.
Well, you need a cutoff for the model, right? You don't need a cutoff necessarily for the biomarker. And in the paper that I referenced by Dr. Sinha and Lancet Respiratory last year, we tested a couple of different cut points for that model. But it's different from a cut point for the biomarker specifically, if that makes sense.
Yeah, thank you. The next question will be to Dr. Cove. Would there be a role of ECCOR in patients with acute core pulmonary and ARDS who have hypercapnia and dilated RV as well? And if correcting the hypercapnia using ECCOR would also have some benefits in terms of stabilizing hemodynamics?
Yeah, so it depends on the ECCOR device and the cannulation strategy. But I think if hypercapnia is what's driving your pulmonary hypertension, which is what's driving your RV failure, then it would certainly have a role. But then you're going to need more carbon dioxide removal. So I think that the thing to understand with carbon dioxide removal is you kind of have the two groups of patients. So the groups of patients who are hypercapnic because of what you're trying to do with the ventilator and trying to protect the lungs as much as possible, those patients, the ECCOR device tends, particularly the low flow ECCOR device, tends to be much more successful at controlling carbon dioxide levels. But if you've got a patient that's already hypercapnic and it's not because you've dialed back on the ventilator, those patients tend to require higher flow ECCOR. So you won't be able to use low flow ECCOR. So then you're starting to get into blood flow rates of 1 liter or more per minute. And then the whole management becomes a lot more complicated. And if you've got a patient that's heart is failing, it's right heart or left heart, the actual question should be, do I need to be thinking about a different form of extracorporeal support and be providing circulatory support with a ECMO or an RVAD or an LVAD?
Thank you, Dr. Cove. I think that's all the time we have for questions today. Thank you once again to our 4 speakers for sharing their thoughts and insights on ARDS. We are very honored to have the 4 of you speak today. I think our takeaway point from this symposium is that indeed it appears that ARDS is a heterogeneous disease as we learn more about it. And in the future days to come, in terms of management, would most likely require more and more of an individualized approach. Thanks a lot for being here with us today.
Thank you.
Thank you.
Thank you.